Good evening, one and all. A warm welcome to the today's CME program arranged by Indian Medical Association Sullia. This is the second online CME we are arranged here. Very warm welcome to all doctors of Sullia, IMA, and the students, and IMA executive members. I welcome one and all. We will start the program with IMA prayer. Dr. Ravikant, our secretary, will do the prayer now.
Thank you, madam. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವಾಗುವಂತೆ ನಾವಾಗಿರಲಿ. ಭಾರತೀಯ ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವನ್ನು ಮಂಡಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮಗೆ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಮಾನ್ಯತೆ ಪಡೆದಿರುವ ರಾಷ್ಟ್ರ ಸಂಸ್ಥೆಯ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ನಮ್ಮ ರಾಷ್ಟ್ರ ನಿಷ್ಠೆಯನ್ನು ಶಪಥ ಮಾಡುತ್ತಿದ್ದೇವೆ. ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ.
Dr. Girish S. Sir, thank you.
Thank you, Venkat Krishna sir. And now next we will move on to the speech today, CME, cardiac advances in cardiac disease and the preventive measures by Dr. GIRISH S GODBOLE. Yes.
Thank you, Dr. Veena, Dr. Venkat Krishna Bhatt, Dr. Ravikant, for having me on this program. I was delighted to see that you have a prayer, you have such an active program. So congratulations, and I hope you continue to thrive. My talk today, I'm going to divide into essentially three parts. One is, first, I'll start and I'll try to dazzle you by telling you what is possible in terms of interventional cardiology in India, in Bangalore, in parts of India today. So this is already here. So this is part of our current practice. So that is one. Second is, in the last few years, there have been very many exciting advances in medical management of heart diseases, as also my favorite topic, though I'm an interventional cardiologist, my favorite part of the whole thing will come last, which is how to prevent cardiac problems. So let me just share my presentation. Can you see my screen?
No, not started.
Okay, I will just, I did share it, but let me. I have shared. Kanasta idya?
Barlilla.
Okay, so you have to pin my screen hege, because I've made you co-host, Veena. Is that?
No, you host ide.
I have, but it's not.
Share screen coding. Started, yeah. Screen bantu. Yes. Yeah, good.
Okay, now you can see that. Right. Right. Okay. So let's get started now. One of the right. Okay. As you mentioned earlier, both the incidence and prevalence of cardiovascular diseases has been very steadily increasing in India, and it's now replaced infectious diseases and respiratory diseases and infections as the leading cause of mortality in the country. And this trend is going to go on at least for the foreseeable future. Now, having said that, parallelly, there have been a lot of advances in both cardiac diagnostic as well as cardiac therapeutic modalities, and that has changed the scene to a dramatic extent. And a vast majority of these interventions are available in India. So this is not something which is science fiction. We do this actively. We are participating in a lot of studies. And overall, a lot of the interventions that are possible, most parts of the world are possible here. So if you look at what has been happening in terms of cardiovascular diseases, the incidence, especially if you look at our country here, you see that there's a lot of brown and rust here. And especially if you look at Karnataka, the percentage change is plus about 15% in just in the last 20 odd years. So which is a huge increase considering how much a population has grown. And if you look at the absolute number of deaths, the number of deaths numerically have increased, and the numbers in India have increased phenomenally over the last 10 years. But and a lot of these factors, a lot of these diseases are accounted for by ischemic heart disease and ischemic strokes, which is roughly 2/3 of all the cardiovascular deaths. So it is of crucial importance. There haven't been too many changes in terms of what has been causing, what are the risk factors that are causing the cardiovascular diseases. So you see high blood pressure, dietary, habits, high cholesterol levels, all these things have continued to be there. But if you look at the trend globally, we are becoming more and more obese. So your body mass index is increasing. But worldwide, if you look at the trend, the tobacco consumption is coming down, though I can't say it's the same with our country. The good thing is the mortality across the ages has been coming down, both amongst both genders and across age groups. So all vascular mortality from about 6 per 1,000 is now about 2 to 2.5 per 1,000. And this is fairly recent data. So the prevalence is increasing significantly, but because of a lot of advances in diagnostic and therapeutic modalities, our death rate has come down and is continuing to come down overall. Now, a lot of these changes have happened over several decades, starting with the first open heart procedure back in the 1950s, all the way past surgical modalities, beta blockers, the concept of CCU, angioplasty in the 1970s, implantable defibrillator, statins, aspirin, fibrinolysis, stents, cardiac resynchronization therapy. And so there has been there have been very many landmark advances which have happened over the decades. So what I'm going to try and do now is to focus on what has happened in the last few years, probably in the last decade or so. I'm just going to briefly mention this. It may not be as widely available everywhere as it is in major metros, because these techniques and technologies require both the hardware as well as the expertise to interpret the finding, to give a good report, accurate report. But CT scans and cardiac MRIs have been advancing quite a bit, and we are utilizing them more and more. And as we speak, it is evolving. The technology is getting better. The resolutions are getting better. But as I said, there is limitation as of now as far as availability is concerned and the ability to interpret the images that you acquire. So CT scans are very useful, and the use is evolving from normal coronaries all the way up to functional imaging is technologically possible now, though, as I said, it's not very widely available, but this is going to evolve. So this is going forward, you will hear a lot about CT scans, and it's going to change a lot of our practices because it is applicable in a wide variety of indications. The addition of functional testing to CT scan static images is going to change the field in a big way. That's over the years. So this is just something for you to keep in mind, because you will probably be exposed to a lot of this. And the CT scan has an excellent negative predictive value. So if you obtain good images on a CT, and if your blood vessels appear normal, you don't have to go further. So that's how good it is. Similarly, cardiac MRIs, they are evolving. We are using cardiac MRIs to document ischemia, to assess viability of heart muscle, and it's also especially useful for tissue characterization and especially useful in cardiomyopathies. But here I come to the intervention part, and there are a couple of things which have changed, which have drastically altered how we interventionist practice. And one of them is that we do a majority of our cardiac vascular procedures via radial access now. So either two, in fact, when I was training both in UK and here, the practice was always to get femoral artery access. And there are a number of problems with femoral artery access. It's not easily compressible. As our population gets more obese, the vascular complications are higher. You could have pseudoaneurysms and retroperitoneal bleed. Patients can get a little uncomfortable because you need to keep the leg immobile for some time. It takes a few hours for you to mobilize. But it has been used over the decades. A lot of us, who learned in the previous era, probably were more comfortable with femoral access rather than radial. But then we have shifted. Now a majority of my interventions, probably 95% of my diagnostic procedures and interventions are through the radial route, because a radial artery is very easily compressible. It's very easily accessible, even amongst obese people. There's very little pain. There's no immobilization. You can always, you can literally walk off the angiography table. So that part of, so this has changed things quite a bit. And it is not just the fact that the patient is more comfortable, it also translates into better outcomes. So all-cause mortality, bleeding, and vascular complications are reduced significantly when we do transradial, including in acute MI. So we are talking about widely, the wide usage of this technique. And that's what we do. We don't do transfemoral so much unless there are specific procedures which require large catheters. So, one of the limitations of radial access is that the catheter size has to be smaller. We can use a maximum of 7 French, especially in men. Women probably 6, but that's where it is. So if you need to use a larger access, you need a bigger artery to go through, which is where we still depend on femoral. Let me come to coronary interventions. And basically, if anybody has coronary artery disease, we have one of 3 options. Some people are okay with medical treatment. Some people will require interventions with placements of stents, which is percutaneous interventions. And some people will require a bypass surgery. So how do we make a decision? So when a patient comes to us, are the symptoms typical? What are their comorbidities? How fit are they? What are their likes, dislikes, so on and so forth? Many times we do non-invasive tests, whether it is a stress echocardiogram or a treadmill stress test. And we use that and we look at the blood vessels of the heart, and ultimately, a lot of the time so far we have made decisions based only on anatomy and how it looks, rather than how functionally significant the lesion is. But the problem is that appearances can be deceiving. And one of the major limitations of angiography is that we can make a lot of mistakes. So it depends on where you're looking from. So a 6 for me might look like 9 to you. So there can be a lot of errors when we do angiography. And this illustrates it very nicely. Here you would think that the lion is probably swallowing its cub, whereas it's lovingly carrying it across. So there are limitations to angiography, and the resolution is not great. It just gives us a luminogram. Essentially, it doesn't give us too much information about the characteristic of the plaque, because a plaque is of various types, and I'll show you that. And so there can be a lot of inter and intra-observer variability, and that makes decision-making very difficult. So we can't make out how the wall is, and sometimes we can make out if there is some calcium, but it doesn't give us all the information. We don't know the composition of the plaque, and how significant, how long is the disease. It can be very difficult. So it's a confession. So we don't like it, but what is true is that irrespective of how experienced we are, and irrespective of how it looks on the angiogram, as many as 1/3 of the time, 30% of the time, we will be wrong in assessing the significance of the lesion. We could over diagnose it, we could also underdiagnose it. So what is the solution? Because end of the day, it does not matter how a lesion looks. It matters whether the lesion is physiologically significant and causing ischemia, because an intervention for an ischemic blood vessel gives you morbidity and mortality benefit, not the cosmetic result. So it is very important to catch all the lesions which are significant, and only those lesions which are significant. So the guidelines rightly say that there should be some evidence of ischemia before you consider a lesion for an angioplasty. So if you look at this picture of an angiogram, you have the left main artery divided into circumflex and the left anterior descending, and this is the right coronary artery. So you will see that there are narrowings in various places. Some are very obviously extremely narrow. You see here that it looks like a hair. The same thing here. This one looks narrow, but not so much as this, not so bad as this. So should we do something about this or not? What about here? What about here? These things, see this here, the ostium of the posterior descending artery, it looks quite tight. What about this? Is this significant? Not significant. So those are the questions which we have to make decisions about in everyday life. And a lot of the time we had to make it based on judgment, how he looks, what the patient, what the ECG shows, echo shows, etc. But we didn't have evidence of ischemia all the time. And that has changed, and changed phenomenally. And one of the important tools we use is what is called the fractional flow reserve. So what is FFR? So it is a technique where we measure the differences in pressure across a coronary artery lesion. So we measure pressure proximal to the lesion, pressure distal to the lesion. So the more severe the narrowing, the greater the difference, that is greater the gradient. So the proximal pressure will be much higher compared to the distal pressure, or to be more accurate, the distal pressure beyond the lesion of a tight lesion will be far, far less than what it should be if it was normal. So it's derived as distal coronary pressure, which is here after a lesion, divided by proximal coronary pressure. There's one caveat, it is doing maximum hyperemia. So we give medications in order to achieve maximum hyperemia, and then we measure the difference across. So we use a particularly, a specific type of catheter, which has two pressure transducers, which is connected to a monitor. So if the FFR is 0.8 or less, that's what most people consider. Some people consider 0.75 or less as significant. If it is 0.8 or more, it's definitely not significant. So doing any intervention to it has no advantages. And if it is 0.8 or less, then it's definitely significant, and there is clearly benefit symptomatically as well as in other aspects, both mortality benefit also in revascularizing this particular blood vessel. So if you look here, the lesions here in the LAD had an FFR done, and though it looks quite narrow, the FFR was 0.91, and so this vessel can be safely left alone without revascularization. Whereas in this artery, when we did the FFR, it is 0.44. It is significantly less, and this clearly requires an intervention. So here, again, a similar example, baseline, you have equal pressures, give adenosine intracoronary. It causes hyperemia of the blood vessel, and then it unmasks the gradient. And here the FFR is 0.73. So it is significant. Revascularizing this blood vessel is useful. So this is leveraging physiology to assess which lesion is significant, and then you go ahead and intervene in that. Now, drug-eluting stents have been are available now for nearly 20 years, and they are now the standard of care. However, there is still a significant problem of stent thrombosis, restenosis of the stent, and those things are caused if the stent is not deployed properly. So it could be underexpanded. There could be malapposition of some of the struts of the stent, so it may not be against the blood vessel wall. There could be reactions because of the drug coating and so on and so forth. So there are various causes of problems which happen. So how do we eliminate that? So we need to look inside, and which is where a technique such as optimal coherence tomography, or OCT, as we call it, comes to our help. So as you can see here, this is what you think you are looking at. This is actually not what it is, and this is can be very deceiving. So this intracoronary imaging technique, this helps in optimization of percutaneous interventions. So it tells us what the lesion is like before we intervene, and it also helps us post. There's another technique also, intravascular ultrasound, which is also used, but this is now largely being replaced in a majority of centers with OCT, and this is what we do. We also do IVUS at Manipal, but we prefer OCT more, and I'll tell you why. So if you look at, how does it work? So essentially you have a catheter which is sent on a wire, and that has a fiber inside, and this spins around and it creates like a radar-like image. So you see the intima, the tunica media, and the tunica adventitia very, very clearly. And I'll show you some stunning pictures. So if you look here, these are actual comparisons between the OCT images, and then subsequently the blood vessel has been dissected and stained, and you see how beautifully this is delineated, all the layers. And this one here has a lipid layer here. This is a plaque here. You see the thing looks different here. This is a plaque which on histology verifies it. Similarly here, this lesion is calcific. You see here there's a lot of calcium here, and again on dissection you see that this is actually true. So the resolution and the tissue imaging you get is fantastic, and our life is a lot easier because of that. We are able to do things with great benefit. So you see as both fibrous as well as a calcific area here. So this plaque is very different. This is a pure lipid plaque. You see great pools of lipid here. This is a person who's the blood vessel which has had a stent. You see these white dots you see here. So these are the struts of a stent. So you would like that to be nicely opposed to the blood vessel wall. But if you see here, this part, there's a tissue protruding through the stent. So now we know that there is a problem here. And if there is a dissection, if there is thrombus inside the stent, so all these things we can see very, very clearly. So it makes a lot of difference to our decision making. So when we do an OCT to the blood vessel before the intervention, about 80% of the time there are changes to how we want to do it. And post that, sometimes we would have said, okay, angiographically this looks okay, but half the time we think we need to do more. So let me show you a live example. This lady underwent a multivessel angioplasty a few months ago, and this was in the right coronary artery. So if you see here, you see all these white dots which are against the intima. So the stent is opposed very well, and you're able to see the whole aspect of the vessel. And after, proximal to the stent, the tissue is healthy. So yeah, so good job, right? Now let's look at the same patient in a different blood vessel. This was a circumflex artery. And if you look at this screen here, if you see these red dots. These red dots are well away from the intima. That means that the stent is malopposed. Again, in a different part of the stent, you see these red dots which are away from the blood vessel wall. The stent is malopposed. So these are highly prone to develop problems, including stent thrombosis and further problems there. So what we did after that was we went back in with the high pressure balloon, and then we opposed the stent. And then you see all the stent struts are against the intima, which is what we want. So this is pre, where you have all these red dots which indicate that the stent is malopposed. And after we have worked on it, you see now the whole thing is nicely opposed. So this lady will do very well. And if we didn't do this, we would probably accept how it looked angiographically, because it looks all right. Let's stop. But when we did that, we realized that this was there, and so it did help in decision making. Now, one of the other things we see now, especially since a lot of our patients are older, is a lot of calcification. So a calcification, the presence of calcium makes a blood vessel rigid. And when it is rigid, it doesn't expand. The blood vessel loses its elasticity. It doesn't expand. Or you have a stent which is which doesn't expand at all, and that is asking for trouble. So how do we get rid of it? So a lot of the time, depending on what the distribution of the calcium is, etc., we would use rotablation, where we would do a high-speed drill through the blood vessel, and that would cause fracturing of the calcium. But again, the reach of this is limited, and you could have very dense calcium which will not respond to this. So what do we do then? Then we borrow from a technology which a lot of the nephrologists and urologists have been using for a long period of time, which is extracorporeal lithotripsy for renal kidney stones, right? So what has been done is that this has been miniaturized now. So we use what is called intravascular lithotripsy, or IVL. So essentially what it contains is a generator, which a very small thing which is portable. And this is connected to a connector, which is, we just have to push it. It delivers a pulse every second. And then there is a catheter, which basically has two emitters, which give out a pulse of 1 every second. So that happens, and that essentially delivers, when the electricity, the emitters, it vaporizes the fluid within the balloon, and that generates sonic pressure waves, and that causes fracturing of the calcium, even if it is quite thick. So this can, and this preferentially impacts hard tissue, and so it doesn't cause damage to soft tissue, which is essentially what we want. So I'll just run this very short video just for you to get an idea of. So that alters what happens to the blood vessel. So if you see here, there's calcium, there's a very thick plate of calcium, no amount of rotablation will get rid of it, so you can't expand the blood vessel. And after the IVL, you see this, the calcium plate is fractured, and this makes the blood vessel more distensible. So this is an example where you see all these stars are a lot of calcium nodules, very thick calcium. And this, the intravascular lithotripsy has destroyed and broken the calcium. So if you see the area of the blood vessels, it's increased from 2.55 square millimeters to 8.3 square millimeters after the stent. So that is how much difference it makes. Right. So getting out of the blood vessels to now, we interventional cardiologists always want to replace cardiac surgeons. So we want to do more and more things, and we want to steal their jobs. So one of the things is aortic valve replacement. So it is indicated for severe symptomatic aortic stenosis, and we have been doing more and more in the last few years. So if you compare operated versus unoperated patient with aortic stenosis, unoperated patients virtually, everyone is gone within 5 years' time of symptoms. So you have to do something and replace their aortic valve. So all these years, the gold standard has been surgical aortic valve replacement, but a lot of people used to be very high risk for surgical aortic valve replacement, and that's how this technology has evolved, where we do it as a percutaneous procedure. So the patient is in the hospital for a very short period of time. There's just sedation most of the time. We don't require general anesthesia, and the patient goes home the next day or the day after. So I'll just show you quickly what one of our patients, which we have done. So this is essentially a pigtail catheter after the aortic valve has been crossed. You see there's a lot of calcium here, and there's another pigtail which is lying here. This is a pacing wire, because when we deploy the valve, it is done under high pressure. So what we have done is that the valve has been opened with a balloon called balloon aortic valvuloplasty. And what you see here is the aortic valve, which has come through the leg into the aorta via a tube. And after that, we are deployed it. It's very important to get the position right. If it is too deep, it could cause heart blocks. If it is too shallow, then you miss the point. So you need to get the position just right. Also, you need to avoid getting the valve across the coronary arteries, which you can see here. And then once we do that, we deploy that, and there you have it. So whatever was accomplished either by a sternotomy and a very complex procedure is now much easily done via this. Similarly, there is an increased incidence of mitral regurgitation, especially with failed mitral reflex or secondary mitral regurgitation because of other pathologies. So again, the surgical mortality can be quite high if in frail people. So one of the indications is, one of the things we can use is what is called a Mitral Clip. So what it involves is that we go through the femoral vein, puncture the interatrial septum from the right atrial side into the left atrium, and through that we come into the across the mitral valve into the left ventricle, deploy the mitral clip, catch the leaflets, and then pin the mitral valve together. So this is an echocardiogram where you see a very wide jet of mitral regurgitation, which after the mitral clip is virtually disappeared. So what essentially happens is that since the leaflets are not coapting and there's a lot of regurgitation, this reduces the orifice area so that the amount of regurgitation is reduced. As we are living longer, we are developing more atherosclerosis. We are also developing more of aortic diseases. And one of the common problems, especially as we get older, is aortic aneurysm. It's also more common in people with bicuspid aortic valves. So there are numerous types, abdominal, thoracic, and some which extends from the abdomen across into the descending abdominal aorta. Again, the gold standard has been surgical repair, but again, it's a very morbid procedure, and we definitely don't want rupture of the aneurysm. So again, endovascular treatment, or EVAR as we call it, has avoided all the surgical issues. It reduced the cardiac complications. The infection is reduced. It's less invasive. Again, you're mobilized and you're home in no time. So just a case, there's not a great case to show only because it's a very complex case. So we have put multiple stent grafts into this, but just to give you an idea of what this can be. So this was a pulsatile aneurysm in this gentleman. And if you see the CT scan, there's a lot of disease which will come about now. You see this whole aorta is swollen all the way across the aortic arch. This is an aortogram. You see this whole thing is all very diseased and very, very wide and impending ruptures and very tortuous. So normally you won't have an aorta which is really S-shaped here. And so this is the stent graft being introduced and positioned across where we want it. And then once we have the position right, so this is where the aneurysm is extending from there all the way down. So we have positioned it there, and then we have deployed. And when you see that, this is the expanded portion, and then this excludes the aneurysm from the aorta. Now, coming to the next important intervention, which is in atrial fibrillation, all of us are seeing more and more. Again, one of the reasons being people are living longer, so age-related atrial fibrillation is far higher. And hitherto, the management would be warfarin and rate-controlling medications. But we had a lot of problems over a number of years with warfarin because it's slow acting, the dosage is variable, different people require different doses. You need to constantly keep monitoring their INR. There are a lot of interactions with food and drugs. You need to keep doing INRs regularly. And so that has been a big problem for a long time, which is where the novel oral anticoagulants or so-called direct oral anticoagulant medications have been invented, as well as now, to a large extent have replaced warfarin. And so the advantages are that the dosage is fixed, the effect is dependable, there's no food interactions and drug interactions by and large, and they're quick acting. So there are 4 NOACs which have been in clinical use. We don't get edoxaban in India, but dabigatran, rivaroxaban, and apixaban have been in use, and we use it regularly. And if you compare warfarin with placebo or aspirin, warfarin is far superior. But if you compare warfarin with NOACs, the NOACs are superior or equal and safer. So that's a huge advantage. So they have effect on mortality, bleeding, as well as stroke risk. I would be happy to share this slide later if anybody wants to keep this in order to decide which NOACs to use in which patient. But by and large, dabigatran and apixaban have the advantage of, in many ways, rivaroxaban has an advantage of being once daily medication, so that is convenient to some people. Now, some people who have atrial fibrillation and have indication for stroke because of clot formation in the atria, you can't give anticoagulation for various reasons. They have a higher bleeding risk, or they could have recurrent bleeding on anticoagulations, or they have absolute contraindications to anticoagulations, or they don't tolerate it. And some people can't achieve effective anticoagulation because they could have strokes while being on anticoagulation, or they're not compliant, or they're just not willing to take it. So in that scenario, what do we do? So now there is a solution for that, and that is what is called left atrial appendage closure. So what is the basis for this? The left atrial appendage is where a majority of the clots which cause strokes come from, which cause embolic strokes, they come from. So if you exclude the left atrial appendage from the circulation, then you're effectively stopping a clot forming there, and that should translate into the clot not embolizing and causing strokes in people with atrial fibrillation. So one of the first devices which was available, first intervention which was available, was what was called a Watchman device. So that essentially, again, like what we did, what I showed you for the mitral valve repair, It involves us going through the femoral vein across the right atrium to the interatrial puncture, entering the left atrium, identifying the left atrial appendage, and deploying a device which, over a period of time, will endothelialize and exclude this from the circulation. There are a number of new devices which have come and being tested, and this is how it looks. This is the atrial appendage being documented. This is the device being deployed, and after that, you don't have any flow there. Again, on echocardiogram, this finger-like thing you see is the left atrial appendage on the transesophageal echocardiogram, and this is after the device is deployed, and you see there is no circulation, no flow into the left atrial appendage, so no circulation, no clot. Right, so one of the other things which have improved in terms of the miniaturization are with pacemakers. So all this while, I mean, if you look at the early pacemakers, you would require a cart to use the pacemaker, and that has over a period of time evolved into smaller and more efficient devices, last longer, easier to implant, easier to use. And then a few years ago, we have what is called the leadless pacemaker. And in future, the technology is probably going to be batteryless, so which means that it potentially is lifelong. So you'll get an idea of how big the pacemakers used to be to now the size which is about the size of a capsule. So one of the issues with conventional pacemakers is that it went through the venous system through these through the veins which go subclavian veins, and then to the SVC down to the RA and RV. So you could create pneumothorax, you could perforate the heart, it could be bleeding at the site of the implantation. You can have lead dislodgement, there could be infection, which can happen in some people. So there are a lot of disadvantages. And also a lot of people don't require to be paced all the time, and some of them require only backup pacing in the ventricle. So in which case even a single chamber pacemaker does. So this is an actual comparison between how big a single chamber pacemaker is versus the leadless one, which is just about the size of a capsule. So through the femoral vein, we enter the right ventricle, we identify the right location near the apex, and then we go ahead and deploy it. And what you see here on this part of the screen is the entire pacemaker, which is a single chamber pacemaker. So this is how we used to do it. This is how we can do it now. But it is a lot more expensive. This is the pacemaker system, which was there earlier, and this is all you see now. As I said, it's new technology, like everything new, it's a lot more expensive. But it's there, it will get cheaper over a period of time as we use it more and more. Similarly, for a defibrillator, for an implantable defibrillator, we used to have to go through the vasculature earlier. Now, of course, we can implant it externally. So under the chest wall and with an electrode near the sternum, and that acts as a very effective ICT. Veena, I'm going to take a pause here if there are any questions, and then another few minutes, and I'll finish. Is that all right?
Okay, prevention part is there, no? Yeah.
So if there's anything with respect to this, I'm happy to answer. Otherwise, I'll continue.
Okay, no. Anybody wants to ask question, they can unmute themselves and they can ask.
Good evening, sir.
Yes, please.
Yeah. Yes, sir. What about in asymptomatic condition if you see a narrowing of the vessel, sir? Asymptomatic patient, but narrowing of the vessel is there in angiography, CT angiography?
Yes. No. What do you mean? What do you do?
Like intervention is required, you just monitor those patients.
Well, if it is ischemic, then yes. If it is not significant, it depends on the location. For example, if you have a narrowing in the left main artery, then it's prognostically significant. Then you can't afford not to revascularize. But if you have it in a very distal part or a distal branch or a small blood vessel, then that doesn't have any effect on mortality. Now, as far as symptoms are concerned, if you have good angina control with medications, and if, as I said, if the lesion is not prognostically important, that is, if it's not in a crucial location, then yes, you can manage the medical. But if it's in a crucial or in a big artery, then you will have a lot of ischemia in a large region, and there you will find that people typically don't respond very well to medications. And a lot of people would require intervention for, if nothing else, for better symptom control.
Then does it mean routine screening is required for angiogram?
Routine screening for what? For whom?
Like high-risk patients are there, the smokers are there.
Sure. Again, I'll address some of it in the section I'm going to speak next, which is on how to modify cardiovascular risk. But yes, see, if the thing is, one, who are you going to screen? You're going to screen people who are at high risk of getting cardiovascular disease. So if you are screening them, then yes, then if you do a CT scan and if it does show significant disease, then you need to look at how ischemic the lesion is. And if it is significantly ischemic, then there is an advantage to revascularizing. If the area of ischemia is very small, then there probably isn't much. So you have to individualize it. But yes, if the patient is at very high risk, then it is worthwhile screening people. If they're diabetic and smokers and obese and which is not hypertensive, so would you want to screen them? Yes. And then, you could do non-invasive testing. Why CT scan? If they don't have obvious ischemia, then you're okay not to do CT scan.
Thank you, sir. And valve replacement by intervention radiologist, what is success rate, sir?
It's very good. It's very good. The complication rates earlier, a lot of it used to be, one of the things, if you look at the data, the earliest studies were in patients who were very sick. Okay, when the TAVR started because some patients were too sick to undergo regular surgical aortic valve replacement. So it started off in that group. Now the procedure is getting done in less and less risky groups. So one of the issues, for example, which I was talking about, MADA or whatever they call it now, this is one of the most fantastic drugs which we have seen, which has significant benefit as far as morbidity and mortality is concerned. So a drug, we see such dramatic effects after a very long time. And this has made a huge difference in people with heart failure and LV dysfunction. So it does potentiate the effect of natriuretic peptides and also inhibits the renin-angiotensin system. And so it has beneficial effects on heart failure with both reduced ejection fraction as well as preserved ejection fraction. It might have other potential benefits also. The other molecular class, which is now revolutionized management of heart disease and diabetes, are the SGLT2 inhibitors. I am not putting in the other molecules because they are not yet available in India. So SGLT2 inhibitors are widely available. And they, again, are every other day there is new evidence coming on how effective these things are in terms of preventing vascular disease. And it's fantastic when you consider that these were accidental discoveries. The cardiac effects, these were not developed as cardiac drugs. They were developed as diabetic drugs. And the effect of these drugs on the cardiovascular system is so fantastic that now we are using this in patients without diabetes. And that there is evidence for that too. So that's how beautiful this these class of drugs are. So they have renal protection. They obviously they will help in control of diabetes, but there's a lot of cardiovascular benefit. So empagliflozin is when the whole story started. Then came canagliflozin, DAPA. So all these are, I think, I'm not sure about canagliflozin, but I know that empagliflozin as well as dapagliflozin are available. And they have a fantastic benefit as far as cardiac events are concerned, preventing heart failure is concerned, and renal disease is concerned. Now, GLP-1RA, I don't think it's available in India yet, though I have heard that they're going to introduce it. But at this point in time, SGLT2 inhibitors are available and they should be used. And I'll come to what is the appropriate setting for that. The third molecule, again, we are using more and more is ivabradine, which basically acts on the funny current or the IF current, and it causes selective slowing down of heart rate without a drastic or dramatic effect on blood pressure. So you use that to reduce, and there is enough evidence now that it helps in heart failure. And we can give 5 milligrams twice a day and up titrate to 7.5 milligrams, depending on what the heart rate response we want. So there have been many studies which have documented its benefit. So I talked about four molecules. So where do we put them? So if somebody has heart failure, first line drugs would be ACE inhibitors or ARNI along with SGLT2 inhibitors. So this is now class 1 indication. And of course, the aldosterone antagonists and beta blockers have been that for a long time. And then, of course, after you have put people on these things, and if their heart rate is still above 70, you add ivabradine and get the heart rate down to say 50 to 60. So these 3 molecules, there is definite indication, and we should all incorporate it in our practice. The last group of drugs is the Pcsk9 inhibitors. So PCSK basically binds to the LDL receptors on the liver cells. So if it's bound, then it can't take the LDL molecule up, and so LDL stays in the blood. So the evolocumab as well as the alirocumab, they inhibit the PCSK9. So that means the LDL receptor is free, and so the LDL can be taken up. So you have a reduction in plasma LDL. So evolocumab is available in India. It is very expensive, but it is available. So we do use it, not very commonly, but we do use it in people who are not well controlled on for their LDL goals, and who can afford it on top of the statin, maximum tolerated dose of statin and diazepam. Right. Now, this is my favorite part. I'll go through this very quickly. So, we start as a normal child, but then with various influences, which is now, for example, technology and abundance of food. We are no longer starving. So now we are malnourished because we overeat and we have food overabundance. Cultural, some people eat for pleasure and nothing else. Then, as you grow older, you start getting on with tobacco and alcohol and what have you. And then sickness leads to all sorts of other things, including surgeries and interventions and drugs and devices and so on and so forth. So we should take an opportunity to tackle this at all the points. So first step is to identify risk factor, risk stratify, number 2, decide what we need to achieve, and then go all out. So your traditional risk factors, which all of us know, diabetes, smoking, hypertension, lipid issues, obesity, family history, etc., etc. But then a lot of risk factors are emerging. There's a lot of research that's going on, and a lot of studies are going on, and all these will, over a period of time, get delimited and incorporated into our risk stratification. So it is a continuum. You have a lot of socioeconomic factors. You have what happens during your growing up years and so on and so forth. And they, over a period of time, cause hypertension, raise lipids, diabetes, etc. That leads to atherosclerosis, and that leads to cardiovascular diseases. So when we talk to patients, typically we ask whether they have this or that, but these are some of the other markers or some of the other what are called risk enhancing factors which we should incorporate into our patient questioning. Now, one thing which I find very few people doing is to risk stratify, use tools. So there are a number of tools available in order to do risk stratification. The thing which works for Indians the most are these two, JBS3 as well as the QRisk. So one could use this and you will know what their lifetime risks are. So this table I'm very fond of because this is made by the Lipid Association of India, and they have classified based on what risk factors you have. So they have looked at what are the major established risk factors, the other high risk factors, as well as the non-conventional risk factors. So this includes quite a few variants. And after that, they have categorized people into low risk, moderate risk, high risk, very high risk, and extreme risk. And I will look at who is what. But once you have this, you know which group the person fits into, and that's how you look at what you need to do. So again, it has to be a team approach. It has to, we need various factors to take socioeconomic factors into consideration, and of course, the various risk factors they have. So, as far as diet is concerned, important diet is in our health. So again, if you want to prevent problems at a primordial level, then you need a societal change. But at an individual level, of course, you have to look at each individual's lifestyle and try and modify that, because that's a big factor. So in general, the recommendation is use more plant-based and use less animal-based food pattern overall. But that again, I have to make one point here. That doesn't mean everything vegetarian is healthy, because it depends on how you prepare it as also, in addition to what you're eating, how you make it. So keep saturated fatty acids low, salt intake low, as much fiber and fruit and vegetables as possible. Red meat to be minimized. Oily fish, good for you. Unsalted nuts, good for you. Again, I tell my patients, don't drink. If you drink, keep them small. And of course, a lot of our teenagers, so we have to start young. So all these sugar drinks, beverages are extremely harmful. And do they really make a difference? Yes, they do. So trans fats definitely increases the risk. The more unsaturated fatty acids definitely reduces the risk. If you get a lot of your carbohydrates from refined sugars, again, increases the risk significantly. Again, there are recommendations from various bodies, but again, all of them go the same way. So proteins, carbohydrates should form about half your requirement. 10% should come, 15% should come from proteins, and about 15 to 30% from fats, and that should be good fats and healthy fats. This, yeah, as you introduced me earlier, yes, I do run not for health, because I mean I do exercise for health, but once you take it beyond a certain level, once you're talking about long distance running, it becomes a sport. So I don't suggest that as something which everyone should do, but certainly as far as exercise is concerned, everyone, irrespective of age, gender, location, whatever it is, you should be exercising. Yeah, it's the single most important health intervention that is available, and it has a lot of beneficial effects on everything, right from brain health. I mean, a lot of people don't know that exercise lowers the risk of at least 8 different cancers, including breast, colon cancer, stomach cancer, bladder, prostate cancer, etc. So it literally helps you from head to toe and costs you nothing. I mean, you asked about, somebody asked about gym. You don't require a gym to exercise. So it's the single most cost-effective health intervention known to man. To broadly finish the exercise recommendation, at least 5 hours a week in separate, and at least of moderate intensity. So what is moderate intensity? So just a stroll is not sufficient. You have to work at a certain speed in order to get the most. This is a problem we are going to increasingly see, the obesity epidemic, which is already there. We are going to have to intervene in a big way. Tobacco, of course, the consumption actually is increasing in our country, whereas in a lot of the Western society, it is plateauing. But this is something which we need to do. So we need to ask, we need to advise, we need to assist and arrange so that they get down. We need to aggressively identify hypertension and we need to control it. It doesn't matter how we control it. We could use pharmacological methods, or more ideally, we use all the non-pharmacological methods, and then if necessary, we add drugs, preferably ACE or ACE inhibitors to start with, and then step by step we go on. Again, as far as HbA1c, diabetes is concerned, one thing I find a lot of people don't do is regularly monitor HbA1c. Please do that. Get HbA1c below 7 as far as possible. And if the risk of cardiovascular disease is high, try and use SGLT2 inhibitors or GLP-1 inhibitors. As far as lipids are concerned, our targets in India have to be a lot more aggressive than what it is in many guidelines. So we want this much lower than it is in the rest of the world. So start with high intensity statin. If you have achieved LDL goal, that's fine. Otherwise, you add ezetimibe. If you haven't achieved it, then add a Pcsk inhibitor or bempedoic acid. Bempedoic acid, we expect it to be launched in India this year. So to sum it up, cardiovascular disease is largely preventable, but a lot of effort has to go in very early in life, and one has to make health a part of one's living. And the disease factors, causing factors are very well defined. We know what causes what, but you have to look at it overall. What is your overall risk rather than focusing only on diabetes or hypertension? And you should target therapy into the highest risk groups and go all out and make sure that you give the highest risk group the maximum intensity. A last point about what you are going to see going forward. You're going to see a lot of wearables and other gadgets which are going to come and make diagnosis a lot simpler, monitoring a lot simpler. And we are going to see a lot of artificial intelligence being used in the field of medicine and certainly in the field of cardiovascular medicine. Right. I thank you for your attention and happy to answer any questions.
Thank you. Thank you, Girish, for giving a wonderful lecture. Open to discussion.
Hello, sir.
Yes, sir.
Yes, please.
Regarding isolated triglyceridemia in Indian setup, how we go about? Because Western literature say more than 885 or something, it's the cutoff or something. But Indian scenario is different. So how we have to go about isolated triglyceridemia?
Be as aggressive as you can be.
Like
I put people on treatment even if it is about 300-400.
Okay.
But we always, I mean, see, again, the context is important. If, for example, somebody has very poorly controlled diabetes. So
okay.
if you control the diabetes, weight loss, etc., you always, unless if the triglycerides doesn't cause 500, and if the person looks otherwise sensible, and so some people we can give a trial of lifestyle changes for about 3 months. See what you achieve. If you achieve a good trend, good reduction, it's all right not to put them on medications. But if it is 500 plus, I first give them medication and talk later. As far as if it's 500 or more. If it's less than that, I look at the overall picture and then take a call. So a lot of the time, 250, 300, etc. Say let's do some lifestyle changes, improve your diet, lose weight if you're obese, control diabetes better if you're diabetic. And in spite of that, it is high, then I would treat it. It is not as strong as a risk factor as a low LDL is, but I would certainly treat it.
Dr. Rajeshwari, please mute yourself. Dr. Rajeshwari. Sir Kudwa, sir, you want to tell something? Yes, sir. Good evening, sir. Mute ಆಗಿದೆ ಸರ್. ಮಾತಾಡಿ. ಕೇಳಿಸ್ತಾ ಇಲ್ಲ?
ಇದೆಯಾ?
ಈಗ ಕೇಳಿಸ್ತಾ ಇದೆ ಸರ್. ಯಾ.
When I was scrolling WhatsApp, I saw this program, so immediately I joined. I thought better late than never. Better late than never. Yeah. Anyway, it's a very useful topic. That is in fact, in this era where youngsters are getting into ischemic heart diseases, and we are hearing day by day various incidences. So all these topics are very much needed. And in fact, IMA should encourage such CMEs at all levels, in fact. So, in fact, we should have repeated CMEs like this at the state level as well, so that whole society should be made aware of the facilities available now. So, definitely, this will take a long way in improving the health of the society. So thank you very much for this wonderful program by IMA Sullia. Keep it up.
Thank you. Thank you for attending and for your encouraging words, sir. Thank you so much. Yeah. If any questions, you can ask, or we can wind up the session. Anybody wants to ask question? Rajeshri, please mute yourself. Girish had mute ಮಾಡಿ ನಂದು host ಹೋಗಿದೆ. Rajeshri. Okay. Ravikant sir.
Yeah, madam. Yeah, please. Yeah.
Stop sharing ಮಾಡ್ತೀರಾ ಗಿರೀಶ್?
ಮಾಡ್ತೀನಿ.
Yeah, as the part of the program, vote of thanks will be given by our WDW chairman as well as the member of our IMA Sullia, Dr. Geeta Duppa. Please, madam.
Good evening, all. So, excellent talk by Dr. Girish S Godbole, consultant cardiologist, Manipal Hospital, Bangalore. Thanks a lot, sir, for sharing all this excellent information. And as you said, the use of tobacco. Yesterday only we had a meeting with all the subcommittees of IMA, where our president IMA KSB said how IMA can participate actively in seeing the reduction of the tobacco use, mainly concentrating on the school and the colleges and talking about the hazards of use of tobacco. So IMA is going to take active steps in this. So wherever possible, we, the members of IMA, are trying to see that all these health hazards, what are there, we create awareness and see that the community at large becomes healthy. So on behalf of IMA Sullia, we wholeheartedly thank you, sir, for this excellent information. Thank you very much.
Thank you.
Yeah. I thank our president, IMA Karnataka State Branch, Dr. Suresh Kudwa, sir, for participating in this program and encouraging us. We wholeheartedly thank you, sir. I thank the President of IMA Sullia, Dr. Veena, Honorary Secretary, Dr. Ravikant, and all the office bearers of IMA Sullia for organizing this informative CME. I thank the editors of Vaidyavarta, Dr. Sri Krishna sir and Dr. Bhavya, for coming up with the issue of Vaidyavarta. I thank Dr. Venkata Krishna for introducing our esteemed speaker of today. I thank the chairpersons and secretaries of various WDW branches of Karnataka, my postgraduates, interns, and IMA members from various branches of Karnataka for joining our CME through Zoom and also through YouTube link. I thank all the IMA members of Sullia who have joined the program. I thank one and all to everyone.
Thank you, Geeta madam, for delivering the vote of thanks to one and all. And again, from my side, as Girish is my classmate, my batchmate, I'm very happy to listen to him, and I was happy to welcome him to our Sullia through online. Thank you.
Maybe Monday I'll come in person.
Yeah, surely, sir. We will be very eager to listen to you in person and definitely get some health tips for us as doctors and also for our patients also.
I think Dr. Anusuya is our classmate. I think so. Anusuya?
Yeah, hello, Veena. It was nice hearing about the talk, Veena as well as Girish, sir. It was excellent talk, sir, Dr. Girish.
Thank you. So this has become a mini reunion, Veena, BMC.
Okay.
Right.
Thank you.
Veena.
Thank you, one and all.
Thank
Yeah,
you.
good
Good
night.
night.
Next time. Yeah. Good night.
Thank you. Thank you.
Good night.
Good night. Good night.
Thank you.
Thank you.
Thank you. Thank you.